Prevention is important because it saves money and helps people. The mission of the Prevention Project is to contribute to a cultural shift in government that embraces prevention. Using a prevention model will benefit society while reducing government costs and budget deficits. The Prevention Project aims to promote interagency collaboration, effective governance, and strategic assessment, implementation, and evaluation through a nonpartisan, multi-systemic approach. On September 10, 2013, the Prevention Project hosted a congressional briefing. The purpose of this briefing was to promote a nonpartisan governmental adoption of a prevention model in order to reduce costs and budget deficits while benefiting society. Representative Bobby Scott of Virginia has a history of promoting prevention of youth violence in his home state and nationally. His office helped to accommodate space for a briefing on September 10th in the Rayburn House office. Representative Scott would like to promote further congressional involvement through a congressional caucus focused on improving governmental adoption of prevention strategies and with additional briefings. A panel was invited to describe benefits on various topics, including healthcare, education, mental health, substance abuse, criminal justice, national security, and disaster prevention. Throughout, the panelists described ways in which prevention strategies can provide economic benefit and improve outcomes such as reductions in crime or diversion from international conflict. For example, cutting high school dropout rates in half would increase government revenues annually by $45 billion by increasing tax revenues and reducing costs of crime, welfare, and public health.
Preventive actions reduce human suffering, and in most instances are more cost-effective than waiting until a problem develops and then trying to solve, reverse, or fix it. From interventions that prevent chronic health problems to those that reduce incarceration, homelessness, or high school dropout rates, using evidence-supported prevention strategies pays huge dividends to individuals, government, and society. Today's event is an initiative of the Prevention Project, a broad-based coalition whose mission is to facilitate governmental adoption of a prevention model for reducing government spending while benefiting society. The project believes in a nonpartisan, multi-systemic approach that includes interagency collaboration, effective governance, and strategic assessment, implementation, and evaluation. The project believes that networking with like-minded organizations, experts, and the public will contribute to a cultural shift toward proactive policies and programs that improve outcomes and save taxpayer dollars. The project encourages those who agree to join in this effort. We must acknowledge several people in thanks for today's event. Most of all, we must acknowledge Congressman Scott for his interest in and commitment to this subject. And the Congressman will be joining us shortly as we understand it, and we'll be lucky enough to hear a few remarks. We must also acknowledge Neil Wollman of the Prevention Project, who is the organizer and engine behind today's hearing. He'll be available at the session break and at the end of the second panel to speak with congressional staffers and other attendees. He is truly the engine behind today's event. Neil, just raise your hand so that folks know who you are. I'll also note Taylor Bishop of the Prevention Project, who will be delighted to speak with attendees interested in participating in the Prevention Project. And Taylor is manning the video camera. She's by the door there. So folks interested in speaking with her at the break or at the end of the event, please do. I'd also like to point out that there's a table of resources. It's just outside the door with literature from today's speakers, as well as the paper, A Prevention Model for Reducing Government Spending While Benefiting Society. There's also a sign-in sheet for folks interested in keeping up to date with the Prevention Project and developments in this area. I hope that folks will write down their name and contact information in order to be kept up to date. I'll introduce myself. I'm Mattea Kramer, the Research Director at National Priorities Project. National Priorities Project is a nonprofit, nonpartisan federal budget research organization with a mission of making the federal budget transparent so that Americans of all walks of life have the opportunity to understand and influence how their tax dollars are raised and spent. I'm also a co-author of the paper, A Prevention Model for Reducing Government Spending While Benefiting Society. Today's events will go as follows. Our first panel on health and education will begin momentarily and run to approximately 3:30. We'll then have a short break, and our second panel on violence and security will run from approximately 3:30 to 3:40 to 4:45. We hope to have time to take a couple questions for each panelist so that there's some discussion after the panelists make their remarks.
I've been working on prevention legislation for a long time. I was a member of the Virginia State Senate in 1987, and Joe Milano talked me into introducing legislation establishing the Virginia Council on Coordinating Prevention. It was coordinated through the Secretary of Health and Human Services, and the Deputy Secretary is here, right here, so Bobby Vassa. So it's just like coming home. The goals of the council were healthy people, healthy children and families, safe and productive communities. And by focusing on these goals, the council virtually included all departments dealing with human services, and sought to ensure that we focused on preventing problems rather than waiting for problems to occur and then spending more money in rehabilitation than we would have in preventing them in the first place. All departments were required to work together because many agencies were solving their own problems by creating problems for other agencies. For example, the Department of Education could get rid of a problem student by expelling them. That's great. That helps the Department of Education. But then you look around in Department of Corrections and Social Services for teen pregnancy has to deal with the problem that's been created. While the council was formed out of concern for the long-term well-being of the residents, we also learned that when we focused on prevention, government would also save a lot of money in the process. So unfortunately, after I left the State Senate to come up here, I looked back and it took them about a year to abolish the council. So I didn't learn that you had to have somebody back there as a watchdog. We could avoid many tragedies and save a lot of money if we spent time and energy needed to implement prevention efforts. A perfect example is violence prevention, and that's what I've been working on, doing a lot of my time in Congress. We've seen too many violent tragedies, often fatal, unfold despite a considerable body of evidence, research, and knowledge that we can prevent many of these problems. We can reduce crime by doing what has been proven to be cost effective, or we can play politics. And you know, the politics is coming up with some rhyme or slogan, 3 strikes and you're out, abolish parole, truth in sentencing, mandatory minimum sentences. If you get it to rhyme, it's even better. You do the adult crime, you do the adult time. All of those have been evaluated and found to have a negligible impact on crime, some in fact actually counterproductive. But we know if we have a comprehensive evidence-based approach that we can reduce crime and save money. I've introduced the Youth Promise Act, which requires the communities to come together, come up with an evidence-based approach to crime, use the money that you save to reinvest to keep the programs going. We're working on that. We're gaining support, and if you know any legislators, encourage them to co-sponsor the Youth Promise Act. One of the advantages in that approach is you get young people on the right track and keep them on the right track. You can reduce crime. You also, because you're empowering them with education and strengthening them personally, reduce a lot of other problems like teen pregnancy, dropping out, suicide, drug abuse. Bad things that happen to children can all be reduced. And then, in fact, if you have a good crime prevention program, it will reduce teen pregnancy. If you have a good drug reduction program, it's going to reduce suicides because a lot of the risk factors are the same risk factors. One of the problems that we have in the prevention approach is that there's never any constituency for prevention. Everything you're trying to prevent, every problem there is, the constituency of those that already have it. So if it's mental retardation, then you're talking about educational services, respite care, insurance coverage, things that affect those that already have it. You're not talking as much about prenatal care that can have a profound effect. And so that's why this is such an excellent opportunity to come together to try to form a congressional caucus on prevention, because if nobody's lobbying for prevention, it won't get done. We know we should all remember the frame oil filter commercial, you can pay me now or pay me later. That's what prevention is all about. And Neil, I'm so happy that you put this together. And we're trying to get a congressional caucus. So I'm going to hopefully be a Democratic lead in that. If there are any Republican staffers here, I think your member might be interested, let C.G. or Ashley or Carolyn or Evan know, and we can get started. But this is the kind of caucus that if we don't do it ourselves, we can't expect a lot of public pressure on the very cost-effective, money-saving initiatives that come from a prevention model. So I want to thank the panelists on this panel and the next panel, Joe for coming back from before, and Bobby Basso, who just retired from the crime subcommittee, coming back, who were involved in the prevention efforts in Virginia that really made quite a difference. We have a published report that Joe had. Joe, do you still? Yeah, we have a published report from the council that is really a roadmap of the kinds of things that we can do if we take a prevention model approach. So, Neil, thank you very much, and thank you for the opportunity to participate.
Now I'd like to begin the first panel on health and education by introducing Dr. Ron Goetzel, who's there at the end of the table. Dr. Goetzel is a research professor and director of the Emory University Institute for Health and Productivity Studies, IHPS, and vice president of consulting and applied research for Preventive Health Analytics. The mission of the IHPS is to bridge the gap between academia, the business community, and the healthcare policy world. He is a nationally recognized and widely published expert in health and productivity management, return on investment, program evaluation, and outcomes research. Dr. Goetzel has led multiple evaluations of health promotion and disease prevention programs at Boeing, Chevron, Dow Chemical, Citibank, Johnson & Johnson, IBM, Procter & Gamble, Duke University, University of Michigan, and Vanderbilt University, among many others. His public sector partners have included King County, Washington, Cayuga County, New York, and the state of Delaware. Dr. Goetzel earned his doctorate in organizational and administrative studies and his MA in applied social psychology from New York University and his BS degree in psychology from the City College of New York. Dr. Goetzel, welcome.
Thank you very much, Mattea. Thank you, Neil, for inviting me to speak this afternoon. I really appreciate it. I did not bring along copies of my talk, but if anyone is interested in having a copy along with references, please give me a card during the break and I'll make sure that you get a copy of it. I'm delighted to be here. As noted, my name is Ron Goetzel, and I'm a research professor at Emory University in the Rollins School of Public Health. I'm also vice president at Preventive Health Analytics, which is a private for-profit company focused on improving the quality and lowering the cost of healthcare services through better use of data. My offices are in Bethesda, Maryland, and Washington, D.C. I'm also a task force member of the Guide to Community Preventive Services that's housed at the CDC, and president and CEO of the Health Project, which annually awards the prestigious Sierra Coop Award to organizations with documentary evidence that their workplace health promotion programs have improved workers' health and also produced cost savings. I'm here to talk about my research, which has spanned the past 30 years, examining the health and economic impacts of workplace health promotion and disease prevention programs, also known as wellness programs. As background, I'm sure that you're aware of the tremendous human and financial toll that's associated with poor health. The high and rapidly rising cost of healthcare services in the United States poses a serious threat to our nation's fiscal security and economic competitiveness. According to the most recent figures, the United States spent $2.7 trillion a year, that's approximately 18% of GDP, on healthcare, almost double the average amount spent by other industrialized countries, and yet the United States has worse health outcomes than countries with much lower levels of spending. Moreover, healthcare expenditures are still increasing, fueled in large part by dramatic rise in illnesses such as heart disease, diabetes, cancer, and depression. Our current healthcare system is unsustainably expensive and is not focused on health. It's focused on the treatment of illness. The financial implications for American businesses are dire. Employers cover the healthcare costs of more than 156 million non-elderly Americans, and they currently spend nearly half of their after-tax profits on healthcare benefits. Higher medical utilization coupled with rising medical costs translate into higher insurance premiums for families, and in addition, with less than optimally healthy employees, businesses suffer large productivity losses due to excessive absences from work and reduced performance while at work. Productivity losses related to personal and family health are estimated to cost U.S. employers $227 billion in 2011. These costs threaten the ability of American businesses to compete in the global marketplace. The high cost of healthcare also imposes an unsustainable burden on federal, state, and local governments, and is the major contributor to annual government deficits as well as a soaring national debt. Government is the largest purchaser of healthcare services, responsible for almost half of national healthcare expenditures. As an employer of approximately 19 million Americans, 4 million of which are at the federal level, government agencies are subject to the same cost pressures as those imposed on the private sector. The direct costs of high insurance premiums for employees and their dependents, and the indirect costs of productivity losses. Addressing out-of-control healthcare costs is a vital component of any long-term deficit reduction strategy, and in order to do so, we need to improve the health of Americans. One of the biggest drivers of rising healthcare costs is the dramatic increase in chronic disease, with obesity being the key underlying cause. Although chronic diseases are the most common and costly of all health problems, they also are the most preventable. The Centers for Disease Control and Prevention has identified 4 modifiable behaviors: lack of physical activity, poor nutrition, tobacco use, and excessive alcohol consumption as primary causes of chronic diseases in the United States. With this as background, it's imperative that Congress crafts a national strategy for healthcare cost containment that includes disease prevention and health promotion as central tenets. We have an opportunity today to transform the U.S. healthcare delivery system from one focused on treating expensive chronic illness to one that actively promotes good health habits and prevents disease. Comprehensive workplace health promotion disease prevention programs offer a potentially powerful strategy to improve the lives of American workers and their dependents. The workplace is where most American adults spend the majority of their waking hours. The workplace is where health promotion programs can be delivered, and employers have a unique opportunity to reach a large segment of the population who would not normally be exposed to or engaged in organized health improvement activities. Along with this opportunity, employers also have a strong incentive to offer health promotion programs because they understand that if you keep their workers healthy and fit, they will consume fewer healthcare resources, miss fewer work days, and be more productive. The health and economic impacts of workplace health promotion disease prevention programs implemented in the private sector at private companies support a strong business case for increased investment in these programs. A meta-analysis of the literature on costs and savings associated with worksite health promotion programs performed by Harvard economists reported that medical cost savings amounted to $3.27 saved for every dollar invested over a 3-year time horizon. This analysis also found a return of $2.73 in reduced absenteeism for every dollar invested. The potential for savings has been borne out by the experience of many large and small employers who've implemented these programs. For example, a recent evaluation of Johnson & Johnson's comprehensive program from 2002 to 2008 found that the company had experienced an average annual inflation-adjusted growth in total medical expenditures equal to just 1%, approximately 3.7 percentage points lower than other large companies. A general conclusion of evaluations conducted by leading economists and researchers is that these programs do exert positive influence on certain health behaviors like tobacco use and physical activity, biometric measures like high blood pressure and high cholesterol, and financial outcomes that are important to employers, healthcare utilization and productivity. To demonstrate the savings and potential for achievement of a positive ROI, that's return on investment, for U.S. employers in private and public sectors, we used an ROI model that was developed by my team at Emory University and Truven Health Analytics. The analysis showed that if you double the proportion of employers offering comprehensive workplace health promotion programs, that would yield significant medical and productivity savings and a positive ROI. Specifically, what the analysis showed that for large non-federal employers, a positive ROI of $3.26 for every dollar invested was achieved, combining medical and productivity savings. Other similar results were seen for the federal sector for OPM workers, where the positive ROI of $3.11 for every dollar invested was achieved through medical reductions and productivity improvements. As a final step in our analysis, we compared the potential savings from doubling the number of comprehensive workplace health promotion programs in the United States to the amount that government would have to invest in increasing implementation of these programs. This analysis showed a significant net savings of $74 billion to the general economy and federal government, resulting from an investment of only $780 million spread over the next 10 years. The analysis just presented projects cost savings and ROI for individuals in the workforce. However, these individuals will become Medicare recipients when they turn 65, and the federal government will then assume the cost of health care for these people. If workers are exposed to effective worksite health promotion programs, these programs can reduce their risk, and the federal government will accrue additional cost savings. As we know, Medicare is a large and ever-growing entitlement program, and much of its cost is attributable to the increase in preventable chronic diseases. Workplace wellness programs have the capacity to improve the health of older Americans before they age into Medicare, saving the federal government many millions of dollars. There was an actuarial study that recently estimated that by making modest changes in the health risk profile of people entering Medicare, the federal government would realize significant savings. For example, if you increase the proportion of people who entered Medicare fee-for-service who are at low risk for certain diseases, in other words, they were not obese, not hypertensive, at age 65 from 54% of the population, which is currently the case, up to 65% of the population, Medicare would realize savings amounting to $30,499 in lifetime costs per beneficiaries, or $1.1 trillion in total savings in 2008 dollars. In addition to Medicare, the savings of private workplace health promotion programs may be passed along to government through indirect tax benefits. First, by improving health, reducing medical spending, and slowing the attendant growth of health insurance premiums, workplace programs can increase tax revenue for the federal government and decrease the proportion of worker compensation that is not taxed in the form of health insurance payments. The exclusion of health insurance premiums for workers' taxable income reduces federal and state tax revenues by $260 billion a year and is the government's third largest expenditure on health care after Medicare and Medicaid. Given the scale of this tax expenditure, there is significant potential for garnering tax savings by reducing health insurance premiums. So in conclusion, our analyses indicate that implementing best practice workplace health promotion programs that appeal to workers and therefore produce high participation rates will yield a reduction in employee health risks, lower healthcare spending, and increase worker productivity, leading to positive ROI for non-federal and federal workers. The federal government is uniquely positioned to leverage its infrastructure and communication networks to disseminate resources, tools, and best practices, expertise to these employers, particularly small businesses with limited resources. Increasing the number of U.S. workers that offer worksites that offer comprehensive health promotion programs has the potential to dramatically improve the economy and the health of Americans. And thank you.
Next, I'd like to introduce our next panelist, Dr. Diana Fishbein. Dr. Fishbein is a senior fellow directing the Transdisciplinary Science and Translational Prevention Program at RTI International. She is also an adjunct associate professor at Johns Hopkins University and the University of Maryland Medical School, a faculty subcontractor at Georgetown University, and a guest researcher at the National Institute on Drug Abuse Intramural Research Program. Studies conducted by Dr. Fishbein utilize transdisciplinary methods and a developmental approach to understanding interactions between neurobiological processes and environmental factors. The ultimate goal of this research is to translate scientific findings to practice and policies designed to prevent mental health, emotional, and behavioral problems. Given the inherent translational nature of this research, she's created a cooperative for translational solutions to prevent risky behaviors, the Prevention Co-op, a national consortium dedicated to the transfer of knowledge from the basic to the applied sciences, as well as practical settings and public health policies. Dr. Fishbein, thank you for joining us today.
I do some brain imaging, and ROIs are regions of interest in the brain, and now I know it's something different in this venue, so thank you for clarifying that for me. So thanks everybody for spending your precious time here with us today. I'm going to be talking about science to society, preventing mental health problems and substance abuse. A little personal evolution just to help you to understand what my investment is in this. Yes, that is me, and you are the only people who have seen this in quite a number of decades. I dished this out, now you know how old I am from the license plate. I know what adversity is. I grew up in an area that was very criminogenic and anti-Semitic. And so it doesn't matter, what the nature of the discrimination is. If you've been discriminated against, you know what the outcome is for those who are the targets. I went through quite a lot of what we now call hate crimes or bullying. I was beaten on a pretty much regular basis to the point of unconsciousness on the playground, and even hit by teachers. And I didn't understand what it was. I didn't understand why. I thought I was defective. I had no idea it was because of my ethnicity. And so I feel that I have a sense of what so many children in this country go through. And adversity is such a major trigger of all the major mental health disorders and substance abuse that we know of. So I really want to focus on this. I decided I was defective. And can you imagine a child growing up thinking they're defective? How many millions of children in this country grow up feeling that they're defective for similar reasons, and for various other reasons as well. And it's something that I never want another child to experience. And so my heart and soul is in this work. I decided when I was in 5th grade what I was going to do for a living. I had just sort of a general idea that I wanted to understand individual differences, because even though the neighborhood I grew up in was full of crime and violence and guns and all kinds of stuff, gang wars, I call it West Side Story, even though it was like that, there were so many kids that came out okay, that were resilient. And I apparently had some resiliency. I thought it was my intact family that was, I had that support network that other children didn't. But the idea behind my research in these past 30 years has been, what makes us different? Why do some respond negatively over time and do not have good outcomes and suffer a variety of ailments, not just mental but physical, while others do better? And so it led me to a fairly complex study of human behavior. So, I do have been doing this sort of research for 30 years, and I'm now, going from the discovery science to let's tell everybody else about this. We know so much that, it's very important that this become, that there's a public awareness about it, and that we can alter policy, change them, what we know from the scientific venue. So I've merged into this area of translation, trying to bring science to society in terms of practices and policies, and that's what the nature is of the talk today. I've done a variety of things. I'm not going to get into it because we really don't have a lot of time, but I've had a lot of different experiences in my work in the community, in jails. I baby taught here. I taught a class for female detainees in Baltimore City, which was the hardest thing I've ever done in my entire life. I taught them prenatal care and parenting. It was just my little on the side, primary prevention thing. I eventually went to the Justice Department for a year, hoping that I would have an impact on policy, but it was a difficult and probably not a good time for that sort of message to really be played out. And now we're working on trying to apply science to what we call promised neighborhoods from the administration's effort to rebuild high poverty neighborhoods. And so we're trying to take the science into high poverty neighborhoods and try to apply comprehensive interventions that will help to build that support network for children who don't have other options and don't really have a way out. And that's where prevention comes in. So as part of this transition for me, which I feel is something I've been working towards my entire career, I developed this Cooperative for Translational Solutions to Prevent Risky Behaviors. I just called it COA. And it was an extension of an NIH conference grant. There were 2 meetings. Everybody was so enthusiastic about what we could potentially be doing, where the rubber meets the road. You'll hear that expression from me again. What can we do with science where the rubber meets the road, where it really matters, where people's lives can be affected? And so we've developed sort of a loose consortium of individuals, a lot of scientists. We have some educators and community organizations and practitioners, policymakers, and advocates. And it's growing. We've just started to create this in the last few months. It's growing. And our vision is to improve child development and well-being by encouraging scientists to build bridges with child-serving organizations, advocacy groups, and influencers of public policy and media, and also to promote public understanding and adoption of the evidence to improve chances for children to grow and lead successful, happy adult lives. So this is the state of the science. I kind of have this double, seemingly contradictory message, and that we need to know more, but we know enough. So we need to know more. There's a need for more research. Obviously, we're not out of a job. So if you're in science, there's a need though for us to do more interdisciplinary research so that the basic scientists are working with the applied scientists and the intervention scientists and the policy scientists. So there's a real need to have much more collaboration between disciplines to really understand the etiology of these behaviors of mental health problems and substance abuse. Prevention programs need to be targeted to what we know about what the causes are, otherwise they won't work. So it's really important to understand the etiology of all the various causes and generators of problem behaviors in order to make prevention programs most effective. And we also need, from a research perspective, to know more about implementation and the sustainability of the interventions that we are using. But we know enough. We know enough to be doing something. Very little of what we know reaches the public and private sector. So, we publish for each other. We all read each other's work. It's very nice. We get a lot of, nice long CV, and everybody's happy. But there's nobody that goes into science that doesn't really want to improve the human condition. That's what we go into science for, and we don't want to lose sight of that. So it's really important that we get that message across to the public and private sectors. I've discovered that people don't even know what prevention science is, interestingly. In fact, I was called to jury duty a few months ago, and when the judge asked me, I had to go up, and the judge asked me what I did for a living. I said cognitive neuroscience. He said, neuro what? I'm a judge, a very well-educated judge, did not know what neuroscience is. So, these are things that we really need to get out there. How is it relevant? How is it relevant that the environment impacts on the brain to affect the development of children throughout the life course? It is highly relevant, and educated practitioners should know this information, and it's largely our fault, the researchers, for not spending more time to get that information out. So basically, public health, education, criminal justice policies remain relatively unaffected by prevention science, even though we have enough evidence, enough knowledge to exert an impact on a community and population level. This is a slide from NIDA, the National Institute on Drug Abuse, showing what the last 2 decades of alcohol, cigarette, and illicit drug use look like. We've made a dent to some extent in alcohol. We've made a big dent in cigarettes. Public media, education, those sorts of campaigns, it took 30 years, but it really made a dent. Look at illicit drug use. We've had no impact, and we know so much. So this is testimony that we really need to get the word out in terms of what interventions work, and we need to implement them, we need to sustain them, we need to support them on a national level. This is the cost of youth problem behaviors. It's just staggering, just staggering. There is an epidemic of mental, emotional, and behavioral disorders among children and young people that dwarfs the polio epidemic, and nobody is immune. It crosses all social boundaries. Certainly there are more triggers in high-poverty neighborhoods and so forth, but in terms of the effects of these social conditions and other things that lead to mental health problems, there are no social boundaries. So it's just staggering, these numbers. Here's another one that indicates what the most costly children's conditions are for Medicaid costs and so forth. The most costly children's condition are mental disorders. That's over and above asthma and COPD, trauma, acute bronchitis, and infectious diseases. Mental disorders among children are the most costly. The treatment of mental disorders carries the highest cost of the top 5 most costly children's conditions, totaling $8.9 billion. So that's huge. So mental health problems, from adolescence into adulthood, it's the leading cause of disability in the United States for people between the ages of 15 and 44 years old. And the burden exceeds the results from any other health condition. The annual quantifiable cost of these disorders has been estimated to be about $247 billion. Research shows that every $1 invested in overall prevention services yields a return of almost $10. So the numbers speak for themselves. In terms of drug abuse and addiction, into adulthood. So now we're not just talking about experimenting and so forth and some problem behaviors amongst young people. We're talking about diagnosable problems with drug use. The economic impact of addictions is estimated at $500 billion annually. Every $1 dedicated to prevention is estimated to save between $7 and $20 in costs from quite a number of things listed here, and there are more that I didn't list. Crime, incarceration, emergency room care, school dropout rates, mental health treatment, broken families, productivity, and premature death. The economic reality alone dictates that we must prevent that which is preventable. This is the Institute of Medicine report. The scientific foundation has been created for the nation to begin to create a society in which young people arrive at adulthood with the skills, interests, assets, and health habits needed to live healthy, happy, and productive lives in caring relationships with others. So again, the scientific foundation is there and needs to be acted on. The fact is that prevention science, that so few know about, is among the most rigorously proven science there is for helping human beings with social, medical, and educational problems. And this fact tends not to be known because we don't have a big mass marketing budget to get the word out, as there is for other diseases and problems that we have in society. And that's why we're here today. Importantly, in this slide, you'll see the age of each symptom and the age of first diagnosis for these various mental health and substance abuse problems. We can't wait until the first onset of a symptom or the first warning sign or the first sign of a disorder developing. We need to act before these warning signs occur, or at least as they occur. So the point here is that the earlier we intervene, the more effective it's likely to be. If we wait and these disorders become entrenched, then we have more problems. And it's much harder if they become much more intractable. These disorders, all of them, are also developmental. So this is just an example of cannabis use disorder. And as you can see, the onset is in adolescence. Most disorders begin to emerge in adolescence. And again, it makes it very much important to realize that we need to intervene before the development of these disorders. Interestingly, brain development is, there's a very protracted period of puberty or adolescence. We used to think that adolescence somehow magically ended at the age of 18, but it actually doesn't end until the late 20s, when the brain begins to diffuse or finalizes the process of full development. So the prefrontal cortex here has under construction, because throughout adolescence, the brain is still developing and connecting itself to lower centers to exert cognitive control over impulsive behaviors. And it's very important to realize this, because that's when risky behaviors begin to emerge in adolescence. Even normal adolescents engage in risks. The problem becomes when adolescents have more of the triggers, they're exposed to more of the triggers that can cause them to be sort of at that extreme end of the continuum, so that they engage in even more risky behaviors than normal adolescents do. So we have an imbalanced adolescent brain with a lot of emotional reactivity, and anybody who's had kids knows that adolescence is heck. A lot of emotional reactivity and not nearly as much cognitive regulation over their emotional responses. And so it's sort of a double jeopardy, because their social demands and their opportunities and their newfound autonomy are very high for engaging in risky behavior, and they don't have the internal cognitive controls in place to hold it at bay. And so it's very important that the environment is protective, and that their social environment and the surrounding environment is protective against high-risk behaviors during this period of time. And importantly, all of these problems are triggered by similar environmental conditions. And this is another venue for prevention to be very effective. Psychological and behavioral problems occur in the context of a lot of other problems in the social environment. Poverty, certainly, discrimination, a hazardous physical environment, and so forth. And what we know without question is that at all levels they involve stress and adversity as triggers. We know very well that substance abuse onset, the initial substance abuse episode, is frequently preceded by stress. It's stressful to be an adolescent, but with other things, that kids that have dysfunctional homes and other things in their environment that are stressful to them are more likely to onset early. And we also know that stress causes an escalation in drug use. It leads to substance use disorders, including addiction. It's very highly associated with episodes of relapse. And during treatment, people who are stressed and have a lot of adversity tend to be more intractable. So stress and adversity acts on these syndromes at every level. Poverty, as I say here, is by far the most looming risk factor of all for all of these problems and more. So maltreatment, poor parenting, family dysfunction, deprivation, that we see in high poverty or low stimulus environments, ill-equipped schools, inattention to special needs, et cetera, et cetera. So this is sort of a sobering figure, but the United States has the second highest proportion of children living in poverty among 25 of the most developed countries. And it's now higher than it's been since the 1960s. But what's important here is that health and social problems are closely related to inequality in rich countries. And if you can see, I don't have a pointer with me, but the United States is significantly outside of the curve when it comes to this relationship between inequality and social and health problems. At the crux of the problem, on a more individual level, is that self-regulation of behavior and emotion underlies all aspects of mental and behavioral health and their disorder. So when I was talking before about how the prefrontal cortex is not quite formed until the late 20s, the prefrontal cortex it subserves, it helps to regulate the development of executive cognitive functions. And those are the functions that help us to assess our environment, assess risks and benefits of our behavior, make good decisions, be goal-directed, and control impulses, so on and so forth. So executive cognitive functions are absolutely key to self-regulation, and they are completely intact until the late 20s, as I said before. And the prefrontal cortex, again, still under construction throughout adolescence, also regulates emotional and stress responses. So if there are delays in the development of the prefrontal cortex, the development of these executive cognitive skills lags, they fall behind and can be in deficit. And interestingly, and very much known to science now, is that stress and adversity actually causes delays in the development of the prefrontal cortex. And it's actually a very profound connection, and that you can actually see, for instance, in children who have been abused and neglected, that areas of their brains are smaller in terms of their volume, and that they're not as well connected in terms of the matter that connects the different regions in order for one to control the other, and that they're functionally delayed. So these are very, very strong findings showing that stress very tangibly affects child development over time. What is the counteraction? What can prevention do about this? Evidence-based programs capitalize, even if they don't know it, they capitalize on the brain's plasticity. The brain is very plastic through the late 20s. And so there's potentially saying, oh, well, it's hard to change in adolescent, it's too late. It's never too late. I don't think it's too late in adults, because there's a lot of reconnection, rewiring that can be done in adults. Certainly it gets harder. It's a lot easier to alter the brains of children. These manipulations, environmental manipulations that are part of evidence-based prevention programs have potential to actually rewire and nurture the brain so that it can have a trend towards normalization, so that children have a chance. So having access to these interventions is very important for their development, particularly when their environment is deprived. So, and these evidence-based programs work to nurture and rewire these systems by actually helping to develop and strengthen these executive cognitive skills that are needed to function well academically and socially. And doing so, it actually targets the entire range of problems, of youth problems that can stem into adulthood. So these evidence-based programs have a very powerful effect if done right, and I'll get to that in a second. Okay. And these interventions can lead to a final common pathway to a successful adulthood. So how can we apply what we do now? Evidence-based programs target what we know about etiology, including socio-emotional and cognitive functions. They can help to strengthen and reinforce these skills. The potential lifetime benefits of preventing MEB, is mental health, emotional and behavioral problems, are greatest with early intervention. They must be sustainable in order to exert a long-lasting effect. And they are available for the prenatal period through adolescence. So we are not short of programs that are considered to be evidence-based by very stringent criteria. Most have been shown to prevent multiple problems, not just one. And most important developmental targets are families and schools. So appropriately targeted interventions may also be very particularly important for disadvantaged children. A science to society approach can produce results that were unimaginable a generation ago if done well with proven solutions. This is just an example of the various interventions that are available by developmental phase. So there are different categories of interventions that I'm not going to get into. But we have learned how to make a difference in children's lives. And there are a few examples here about how they can help children function going forward into adulthood. So it's not just seeing immediate effects, but if sustained, they can show effects for a longer period of time. So in the long run, a 2005 analysis showed that early childhood programs for vulnerable populations would dramatically increase savings. By 2050, there would be an annual federal state government budget savings of $61 billion, a GDP increase of $107 billion, and a crime savings of $155 billion. The Institute of Medicine has, assessed, as I said before, the situation is concluded. There is no concerted federal presence or clear national leadership that currently exists to advance the use of prevention and health promotion benefits for the benefit of mental and behavioral health of patients, young people, and infusing this approach into the public's consciousness requires that we share this public vision. And this is my last slide. And so just real quick, what is needed? We need a national effort to implement tested and effective programs, policies, and practices throughout the U.S. This requires coordination of all federal agencies that have responsibility for reducing psychological, behavioral, and health problems. There's further research is always needed. And I conclude with our priority should not be on deciding the next war against drugs or homegrown terrorism, but fighting for the peace of mind that all our children can grow up healthy, well-adjusted, resilient, and successful. And I apologize to my other speakers for doing that.
Thank you, Dr. Fishbein. We're going to make one small change, which is that we'll take the remaining panelists and Dr. Goetzel. If there are still questions for Dr. Goetzel, we'll take questions at the end of this first panel after our next two panelists have given their remarks. And with that, I'd like to introduce Dr. Mark Donarski. Dr. Donarski is president of Pemberton Research, specializing in education and social program evaluation. Until 2010, Dr. Donarski was vice president at Mathematica Policy Research and the director of its Center for Improving Research Evidence. He was also the director of the What Works Clearinghouse for the Institute of Education Sciences of the U.S. Department of Education, the principal investigator for its reviews of dropout prevention research, and the chair of the panel of experts that author the Dropout Prevention Practice Guide. Dr. Donarski is a nationally recognized expert in evaluation methodology, including the design, implementation, and analysis of evaluations of education and social programs using random assignment and quasi-experimental designs. He played a leading role in many of Mathematica's elementary, secondary, post-secondary, and adult education studies, including congressionally mandated national study of education technology, the largest evaluation ever conducted of dropout prevention programs, and the national evaluation of federal after-school programs. He is an associate editor of Effective Education on the editorial board of the Elementary School Journal and has served as an associate editor of Educational Evaluation and Policy Analysis and the Economics of Education Review. He has a PhD in economics from the Johns Hopkins University. Welcome.
Thank you very much. Thank you very much, and thank you to Neil and to Congressman Scott for the opportunity. I can't, I'm listening to all that I'm hearing here, and these messages are so common across the topics. It really makes me wonder how it can get to the point where they're not connected, but be that as it may. My focus is going to shift from the other speakers. I'm going to be talking entirely in the K-12 education world, and in particular about the failures of the system in the form of young people who drop out of high school. And so let's just put some numbers out there so we get a sense of the scale of the problem, and then we can work from the numbers and the scale and think about, is it actually a problem that can be tackled with policy? Because as I'm going to argue, you actually can't, if it's a question of prevention versus treatment with respect to dropout prevention, it's actually not a question because you can only really prevent it. We don't have treatments for dropout prevention. So first, the scale of the problem. Dropping out affects a lot of people. It's been that way for a very long time. If at some point, like Diane's presentation showed drug use not having changed in recent years, if you go back to about 1970 or so, you start tracking the trends in dropout rates, they basically are flat. They don't change at all. And they retain the relative position for African American, Hispanic youth versus white youth. The rates are much higher among blacks and Hispanics. So there's an equity issue, a quite serious one. But just the number, among 25 and 29-year-olds, the census reports that 14% of them don't have a high school credential. So these are young people who are not going to probably finish high school ever. They're really much too old to be going back to any kind of conventional K-12 program. They might get a GED yet, but it doesn't. It's very unlikely as you get into that age range. So you're really talking about 1 in 7 young people who is a dropout. So a problem that's at a scale of 1 in 7 young people seems to me like a real problem. You then have the issue of the cost of dropping out. Some economists have been saying it a long time, but recently Susanna Rouse and Henry Levin at Teachers College of Columbia really did a state-of-the-art analysis, and they basically pegged the number at about $350,000 per dropout in terms of the earnings that they're going to give up for the rest of their working lives because they dropped out versus completed. So that's the cost from the earnings perspective, that's the cost to them of having dropped out, to society really, to the economy having dropped out. So you have one number, you have another number, you have 3 million dropouts in that 25 to 29-year-old cohort, you have $350,000 that you left on the table in terms of earnings. You have $1 trillion of foregone earnings for that group. And of course, there's other groups in the economy, all age ranges. So this is a big slice of money that we're simply leaving on the table because for whatever reason, these young people drop out. So in some ways, it's an overestimate because I'm multiplying all dropouts times those earnings as if somehow we're all going to go back to school, which is never going to happen. So you can't think that we're going to somehow gain $1 trillion because you're not going to have everyone complete. But it's an underestimate too because those are just labor earnings. And they don't count things like incarcerations or the health benefits that come with higher education and so on. Those are non-trivial too. That's just earnings. But it's easier to keep it that way because the estimates around earnings are relatively solid, but the estimates of the other things are less so with respect to the gains from not dropping out. So, I'm being conservative here by just making conservative in the sense of not. Okay. Back to the prevention versus treatment. If a young person drops out, they could try to do something else afterward. They could go to Job Corps. They could try to get a GED. They could try to get training on the side without completing high school. There's almost a uniform view of the program evaluation world that none of that's going to matter. At best, the earnings from any of those interventions is going to be enumerated in the hundreds of dollars a year, not in the thousands. So they will never make it back. So really, if we're focusing on what to do about this segment of young people who is seriously at a disadvantage, you have to think in terms of prevention. And I'm going to go further and say, because most of these folks, and I've been studying dropout for a couple of decades now, as you mentioned. Really, most dropping out occurs at the early years of high school, freshman or sophomore years. And so they're not even in high school very long, so high school is not the platform to try to develop the issues. It's too late. In some sense, the problems are very much dug in by this point. You have to think about middle schools, okay? And the first, so when we think about middle school, the first thing we think, well, maybe they're already doing a lot, and it's just not working here. There's already a lot of prevention activities in middle schools. Frankly, middle schools are a data black hole. We know virtually nothing about what's going on in middle schools. Just ask yourself, what do you know about what's happening in middle schools in America? You'd be amazed at how little anybody knows about middle schools. There are no national surveys about middle schools. There are no representative samples going on about middle schools. A fair amount of attention at the Department of Education's National Center of Education Statistics relates to high school longitudinal studies. And those are very useful. I'm not going to denigrate them. But if you started with a set of young people who were, say, in 5th grade and followed them nationally, you learn tremendous amounts about the kinds of services that are being provided to them. But given the history that we've seen of the dropout rate, let's assume, for the sake of argument, that middle schools aren't doing very, very much. So now let's try to to get a sense of, well, can we tackle the scale of the problem in middle schools? Well, there's about middle school, let's call it 6th, 7th, and 8th grades. Some school districts count 5th grade, and others count 9th grade, but let's put it aside. 6th, 7th, and 8th grade, there's about 4 million kids in each of those cohorts. It's 12 million kids. Okay, I just mentioned earlier that 14% of kids drop out. So I'm going to do some multiplication. Okay, so I got about, and I'm going to slightly edge it upwards to be conservative. I got 2 million kids I got to worry about. 2 million kids who are already potentially at risk of dropping out. Okay, what can I do? Well, if I have 2 million kids, okay, let's do some thinking. Suppose I actually invoke a practice which is the root of a successful program called Check and Connect. And I ask schools to hire an adult, and the adult's sole function is to progress the young person through school, resolve every issue they have, just get it done. You know, and Check and Connect has been replicated now in 2 different experiments, and in both cases has shown large effects in reducing the dropout rate. Well, 2 million kids, groups of 20 are about the way the program functions. So I need 100,000 adults. Okay, those of you who have been around for a while may recognize there was 100,000 policemen at one point, there was 100,000 new teachers at one point, so that number has come up before. But if I'm going to try to tackle the dropout problem in middle schools, I need 100,000 adults into the schools. Suppose I pay them like experienced teachers with 10 to 15 years of experience plus benefits. I need $70,000 a person. I need $7 billion. Okay, I have a $7 billion program here. $7 billion is going to basically tackle a whole cohort of at-risk middle school kids with a successful program. Now, there's a couple of weak links in my argument that I need to lay out there. One is, I need to be able to identify the right 2 million kids. If I do a mistake there, the program becomes instantly ineffective, because if I choose 2 million kids who weren't going to drop out, then essentially I reduce the results to 0. So I need to have the right 2 million kids. So, but here's recent developments, and I want to credit Robert Balfons, who's a professor at Johns Hopkins, and his team have created what are called early warning systems. And they basically show that it's very interesting and useful analysis that if you have middle schoolers who have failed math, failed reading, had behavioral problems, or are absent more than 20% of days, any of those indicators clicking on is a higher likelihood of dropping out. And if they're all clicked on, it's a near certainty. So they look at data systems in Chicago, they look at data systems in Baltimore, they look at data systems in Philadelphia, and it was replicated. It's been replicated now about 7 times in around 100 different studies. So, okay, these early warning systems, not very many school districts use them yet. They're very new, but they do hold promise that we can, in fact, identify the right 2 million. So that's good. The other issue is, I actually do need them to not just have that adult. I need the flexibility to handle them all kinds of different approaches to dealing with their issues, because those 2 million kids don't all have the same problem. Some of them don't read very well. Some of them they read fine, but they just have trouble with math. Others have family dysfunction or drug abuse issues or incipient drug abuse issues. So I would like to have a battery of effective program models that I can deploy, so that regardless of the youth issue, once I know what it is, I have something at the ready. I can do this. Okay, here is where the funding shortfall, the vast funding shortfall for educational research really hits. The Institute of Education Sciences has a budget of $650 million, which, like most numbers, seems large in the relationship in Washington. So $650 million is 1/50th the budget of the National Institutes of Health. Now, the oddity here is that the education and the health sectors are about the same economic size within the U.S. Economy. So it's not obvious why education has 1/50th of the funding, especially because our education system is so incredibly fragmented that there's a terrific, what economists would call a free rider problem, in that you don't expect school districts or states to tackle these studies because they are paying for something which is broadly valuable. So we know from economics that generally there won't be enough of that when that's going on. You really want to have more of it, and the federal government has a perfectly legitimate role here in becoming the researcher at the top, the entity whose function is to put out the education research, which all can benefit from. So, one last point of the argument. How effective with those 20 adults? This is interesting. How effective with those? So, I'm sorry, the one adult has 20 kids. So, those 20 kids are the ones who might drop out. So how effective does that adult have to be with those 20 kids to make the whole program break even? And the answer is, for every 5 adults, you only need 1 high schooler or 1 middle schooler not to drop out. And the reason is because if you go back to the $350,000 I mentioned of lost earnings, I paid the adults $70,000. Okay, so for every 5 adults that I have working in this program, I only need them to convert 1 out of 100 middle schoolers into not a dropout. And the program breaks even from a social standpoint. But let's make it break even from the tax standpoint, because you're paying these with tax dollars. Suppose there's a 20% tax rate. So for every dropout returns $70,000 back to the government as taxes. Well, that's what I paid that one person. So if each of those caseworkers can, out there 20 kids, have one of them succeed rather than fail. Program breaks even as an investment, even, not just from a social standpoint, but from the government spending standpoint. So now it seems like a deal that way. And if you can do better than that, everything from there on is a plus plus. Let me finish with this. I want to read a couple of quotes from Franklin Delano Roosevelt. Well, first of all, because there's really good quotes, but secondly, they do actually help me make the point. Franklin Delano Roosevelt said that these quotes were in 2 different places, but it's common sense to take a method and try, and if it fails, admit it frankly and try another, but above all, try something. Okay, so very American spirit, just push ahead. And then he also said in another context, the school is the last expenditure upon which America should be willing to economize. It's really great. So you have a significant dropout problem. You have ineffective treatments. We don't really have a sense that prevention is effective or even occurring, but we have a sense that the problem is at a scale that can be tackled. So just looking at the evidence, I really hope policy can do something. I really hope we can try something. So, thank you very much.
Kristen Norwood. Kristen Norwood is the founder and executive director of Health People, a prize-winning peer education program which trains and empowers people affected by chronic disease and HIV to undertake proven prevention and self-care education that demonstrably brings down costs while improving health in the nation's poorest urban congressional district. In 2005, Ms. Norwood was one of 1,000 women from around the world chosen for a groundbreaking Nobel Peace Prize nomination honoring women's local work. Welcome, Ms. Norwood.
Thank you very much, Congressman Scott, Neil, everyone here. I think we're all really, really happy to be here. And I may say in public life we are often happy for what's called a win-win. My presentation is called Win-Win-Win. And this is to emphasize the extraordinary potential of community-based disease prevention and self-care in an age of chronic disease. This is an age when tested, evidence-based education has over and over proven to be the most powerful strategy, repeatedly more effective, and of course, cheaper than medication. Moreover, people with modest educational backgrounds themselves, including people who don't have high school degrees, can rapidly learn to become local health educators to effectively teach this kind of self-care and prevention. So that's a triple win. You can build jobs in really poor communities that people there can do. These jobs will result in better health and in healthcare savings. There are so many examples. For example, teaching parents proper asthma care for their kids, routinely slashes the children's emergency visits and their lost school days by 50%. You can do effective smoking cessation education as street outreach. Just send your street outreach workers and they connect people hanging out on the street with your state phone counseling center. In HIV and AIDS, which is the only place which has ever had real funding like this in the United States, so it's been very instructive to watch. In HIV and AIDS now, the care and prevention have come so close together because when you get people into care and they are taking their medication, it brings down their viral load and their chances of transmitting HIV go down enormously when they are taking their medication. But I think among the many examples that deserve our first attention is the DPP. Who knows what the DPP is? Thank you. The DPP is the National Diabetes Prevention Program. It is unique, I think, in the history of looking at preventive educational strategies. It's a 22-session course which can be delivered by trained lifestyle coaches. We are currently training people from public housing under the CDC guidelines to become lifestyle coaches to bring the DPP to other residents of public housing. And it has been shown, this 22-session course teaches people how to lose very modest amounts of weight and take up modest amounts of exercise. And it has been shown that this course, if people have high blood sugar, it's focused on people with high blood sugar or pre-diabetics, it brings down their chance of getting diabetes by 60%, which is twice as much reduction in diabetes as if you give the same people standard medications. There are 59 million projected pre-diabetics in the United States. Putting the DPP at community centers, senior centers, public housing, churches, all the many places where people could really have access to it and benefit from it would outrightly change the health of the United States. It would also be at the forefront of changing how we deliver health. Because with community education, it's called community education because it's crucial to have it in communities. We know that most people don't like to go to medical centers unless they have to. To a large degree, they're not going to go to a central medical center, which may be far away from them in any case, to receive this kind of education. So, we want to train people in communities to deliver it from organizations that are there, and this also helps to really change the whole attitude of neighborhoods that are now just totally overwhelmed by these levels of chronic disease. People really see that they can begin to learn to reverse this themselves. Their teachers come from their community, and they themselves are learning how to reverse this chronic disease. And I should point out that the National Institutes of Health has spent more than $100 million in research, proving over and over that the DPP works in different populations. It works for blacks, it works for Hispanics, it works in Appalachia, it works for Native Americans. Here is a case where we have absolutely overwhelming research. You can't ask for any more research. But what we don't have is something that's so well proven, becoming a normal, accepted, used, preventive part of the healthcare system. And that's what I'd like to address myself to briefly today. There is a lot that the Congress can do to make sure that there is access to the DPP and to other evidence-based health education. First of all, it involves providing oversight of the CMS, the Center for Medicaid and Medicare Services. A question we might ask is, Medicaid, Medicare, insurance. Why isn't insurance paying for this course, which costs about $400 when you deliver it in small groups and communities, when someone who gets diabetes costs Medicaid and Medicare about $4,000 more a year than people who don't have diabetes. Another place where Congress can provide oversight and hearings is the National Preventive Services Task Force, which gives expert advice on what prevention is important and works. How can they be so biased against really evidence-based education and the most singularly well-proven evidence-based education that has ever been studied by other branches of the federal government, that the DPP is still not on the approved prevention services list? And finally, Congress itself can step forward. 2 years ago, there was the first federal allocation for the DPP. It was $10 million nationally. It went to the CDC to be distributed. And this year, there is nothing federally going to be allocated to the DPP. A few states are paying for it, or they're trying to use their Medicaid waiver money to pay for it. But there is nothing in an outright allocation from the Senate and Congress. So this leaves us with really some very striking thoughts. Here we have every step, research, rapid ability to put in the field, demonstrated results over and over, but not the final step. The allocation, both through the Congress and through the federal agencies that control the major insurance, Medicaid and Medicare, to actually pay for this. Thank you.
Dr. Lipsey is the director of the Peabody Research Institute and a research professor at Vanderbilt University. He specializes in program evaluation with a focus on programs for at-risk children and youth. His research activities include the study of risk factors and effective interventions for antisocial behavior and delinquency. His meta-analysis research on interventions for juvenile offenders have identified many effective programs and led to recent initiatives to better translate this research into practice. His research has been funded by major federal agencies and private foundations, and recognized with awards from such organizations as the American Probation and Parole Association, the Association for the Advancement of Evidence-Based Practice, the Society for Prevention Research, and the American Society of Criminology. Dr. Lipsey is a member of the Tennessee Criminal Justice Coordinating Council, the Science Advisory Board for the Federal Office of Justice Programs, and the Advisory Committee for the National Science Foundation Directorate for Education and Human Resources. He has served on the National Research Council Committee on Law and Justice, the Crime and Justice Coordinating Group of the Campbell Collaboration, and is co-editor-in-chief of Research Synthesis Methods and Campbell Systematic Reviews. Welcome, Dr. Lipsey.
Thank you, Mattea. It's a pleasure to be here, and thanks to Neil and Congressman Scott. Congressman Scott mentioned the Youth Promise Act, which has a focus on youth crime, youth violence, problem behavior in a prevention context. And I really want to echo that theme, that crime prevention really begins in the juvenile justice system and the related systems that work with it. In this context, we always talk about money, so it's not surprising that the criminal justice system is expensive in the U.S. The total public expenditures for managing adult offenders is in the hundreds of billions of dollars a year. And as you can see in this chart from the U.S. Bureau of Justice Statistics, has been increasing dramatically since the 1980s. The case I want to make is a straightforward one, that much of the criminal behavior of adults could be prevented by effective juvenile justice practices, and furthermore, that we know enough about effective juvenile justice practices to make a big difference. 70 to 90% of adult offenders appeared in the juvenile justice system before their involvement in the adult criminal justice system. Juvenile justice practices that reduce the incidence of first offenses and recidivism after that point could clearly head off the trajectories of much of that adult behavior. And the expense of handling adult offenders, the long criminal careers that chronic offenders potentially have as adults after adolescence, all offer the potential for considerable cost savings at the federal, the state, and the local level in the criminal justice systems. So what does effective juvenile justice prevention and intervention look like? It requires basically a two-tiered approach. Tier one is attempts to prevent first offenses, collaboration with mental health and social service systems to prevent delinquent behavior by at-risk youth before they get involved with the juvenile justice system. And secondly, after involvement with the juvenile justice system, effective intervention with high-risk offenders to reduce recidivism. Recidivism for both juveniles and adults, incidentally, is particularly pernicious because recidivism means that you deal with a juvenile and they come back again. And then they still have a recidivism rate after that, and they come back again, and they come back again. And it works like compound interest, such that a relatively small proportion of repeat offenders makes up a very high proportion of the number of individuals that these systems deal with, and of course the associated costs. The research in this in related areas here has advanced quite a bit, and we have effective validated risk assessment instruments for targeting youth at risk for offending. And targeting is particularly important in prevention. If you are not targeting your preventative services on individuals that are truly at risk for the adverse outcomes, that means that you're spending some of that effort on individuals, juveniles in this case, that in fact are not going to have the adverse outcome, and that's not going to prevent anything. So we need two things. We need effective targeting with instruments that can validly assess risk, at least in a way that allows these systems to play the probabilities. We're never going to be able to predict for every individual. And we need intervention programs that are capable of significantly preventing or reducing delinquent behavior. And we know a lot about both of those things. At Tier 1 in community prevention, just to provide one example, for prevention for at-risk youth, some of you may be familiar with the Communities That Cares model. This is an approach that organizes community stakeholders to do surveys and risk assessments in the community and determine what the high-risk factors are for local youth, and then to address those with targeted evidence-based programming. What's particularly remarkable about this intervention is that it's actually been tested in a rigorous randomized trial, which is quite difficult to do for community-level interventions. The research team here somehow managed to get 24 communities that were randomly assigned to use communities that care, 12 with it, 12 without. What they discovered as they followed over the years, that the targeted risks that the various communities that had communities that care focused on actually decreased. More importantly, there were positive behavioral effects. So the youth in the communities that care communities had 30% lower odds of initiating alcohol use, 21% lower odds of initiating delinquent behavior by 10th grade. And for those in 10th grade looking at prior year behavior, 17% lower odds of delinquent behavior and 25% lower odds of violent behavior at that point. There are other approaches and other effective prevention programs, but the point here is that we do have models that can be used at the community level to target at-risk youth before they get into serious trouble with the juvenile justice system that in fact has been demonstrated to improve behavior and reduce delinquent behavior. Once in the juvenile justice system, then we also have effective evidence-based practices for youth who are processed in the juvenile justice system. And here again, there are validated risk assessment instruments. Targeting is very important at this level as well. A fairly high proportion of juveniles who come into the juvenile justice system are low-risk cases that are never going to return again, and can be managed administratively with some basic accountability, low-cost accountability procedures. The challenge here is to identify the high-risk cases that are likely to return and focus resources on them, and we do have instruments that help distinguish that group. There are numerous intervention programs that, when well implemented, and that's an important side note, well implemented, have been shown to reduce reoffense rates for high-risk, moderate and high-risk offenders by as much as 40%. The challenge is achieving those kinds of reductions at scale in routine practice. Cost-benefit analysis that the Washington State Institute for Public Policy has done estimates that the more effective of these programs save something like $2 to $7 or $8 for every dollar spent, and that is savings to taxpayers. That's savings in public expenditures. That doesn't count savings to victims and communities and all the associated costs. Which is not a bad return on investment. Here are some examples of effective interventions from the work of my colleagues and I. We have spent some decades now collecting rigorous intervention studies with juvenile offenders, have a database of 600 controlled studies, and using meta-analysis techniques have been sorting through what kinds of things are effective. Here's a kind of an overview. We distinguish between what we call control approaches. Over here on the left-hand side, you have essentially negative effects or zero effects on recidivism. So some intuitively appealing things like deterrence, scaring kids away by prison visitation, for instance, or discipline, boot camps, up at 5 o'clock, push-ups before breakfast, and so on, or close monitoring and surveillance. These are not actually effective techniques with adolescents. It has something to do, I think, with the adolescent brain and the impulse control issues here. But there's a wide range of therapeutic approaches. Here we have restorative justice and skill building and counseling approaches. What you're seeing is positive average effects for dozens and dozens of studies. And you can drill down in any of those areas, for example, and you see variable effects, but largely positive effects for behavior management, cognitive behavioral therapy programs, social skill building programs, and so on. The details aren't so critical to my argument. The point is that we actually have quite a bit of evidence of a lot of effective interventions that reduce recidivism for juveniles in the juvenile justice system. A misperception of the nature of the research here, incidentally, is that there's only a small number of name-brand, so-called evidence-based programs that are on special lists that are the only things that are effective. That's not what we find in our database that pretty much collects all of the credible research that's been done on intervention programs. We find that generic versions of those name-brand programs can be equally effective. So you don't have to have name-brand cognitive behavioral therapy as long as you're doing a good quality of cognitive behavioral therapy. You don't have to have name-brand family therapy as long as you're doing a good quality of family therapy. Many of these locally based generic approaches are really effective. The trick is to get them well implemented with adequate amounts of service and adequate service quality. And in many ways, that's more important than the particular type of program and certainly the brand name. So, going to my conclusions, there is indeed much more we need to know about risk and effective intervention for juvenile delinquents. But we know a lot more than is being practiced. There's a lot of untapped potential here in the juvenile justice system to prevent first offenses, kids from appearing in the juvenile justice system at all. And frankly, being caught up in the juvenile justice system is not the best thing that can happen in a kid's life trajectory. And for those that are caught up, we have quite a number of things that can be done effectively to identify those likely to return and do things to minimize that. I would just add, to put this in federal context, Mattea mentioned that I was on the Science Advisory Board for Office of Justice Programs. One of the subcommittees of that board I chair is the one that works with the Office of Juvenile Justice and Delinquency Prevention. There's considerable room for OJJDP to exercise much greater leadership in these domains with regard to use of effective practices and support for effective programs. The funding framework, which has diminished in recent years, like it has for many federal agencies, and the mandates from Congress for particular favored kinds of programs, as opposed to leaving the field a little more open to research and more expert opinion about what's effective in different regards, is not especially favorable there, and there is really much that could be done to improve the leadership role at the federal level in these domains. Thank you.
Next, I'd like to introduce Dr. Lisa Shirk. Dr. Shirk is the Alliance for Peacebuilding's Director of Human Security and Research Professor at Eastern Mennonite University's Center for Justice and Peacebuilding. As part of a team at the Global Partnership for the Prevention of Armed Conflict and the University of Notre Dame's Koch Institute for International Peace, she trains military personnel in relating to civilians and aid agencies to improve conflict prevention. A former Fulbright Fellow in East and West Africa, Dr. Shirk has worked in over 20 countries in conflict prevention and peace building, most recently in Afghanistan, Pakistan, Iraq, Fiji, and Lebanon. Dr. Shirk has written 6 books and numerous articles on conflict prevention and strategic peace building. In 2013, she published Conflict Assessment and Peacebuilding Planning, toward a participatory approach to human security. Dr. Shirk holds a BA in International Relations from the University of Waterloo, Canada, and an MS and PhD in Conflict Analysis and Resolution from George Mason University. Welcome, Dr. Shirk.
Thank you, Neil, and thank you, Congressman Scott, for helping to organize this space and for hosting this conversation today. The field of conflict prevention is part of this larger movement to support prevention. And it really started about 30 to 40 years ago when community groups realized that they could do more than just crime prevention, that they could prevent inter-ethnic, inter-religious disputes, mostly at the community level. The field has grown over the last 30, 40 years to where the United Nations has major programs of investment in conflict prevention, and in 2010, Secretary Clinton announced that conflict prevention was the major goal of the U.S. State Department. So let me take you through a little bit of that journey over the last 30 years and describe what conflict prevention is. I want to start with a story from Iraq. I was in Iraq in 2005, and as you know, U.S. forces were there, and they were seeking to try to stabilize different regions to prevent the insurgency from growing. The group of Iraqis that I was working with were way under the radar. They were not known by any of the U.S. forces or the State Department, but for 30 years in Iraq, they had been running a community-based organization, 40 staff working all over the country, basically to immunize communities against the spread of violence and insurgency. And they had a method where they would help communities form governing associations that were made up of Sunni, Shia, different tribal, ethnic, religious groups, making sure that each community had diversity within its governing structure, and that there were lines of communication and a way for them to resolve conflicts at the local level rather than dividing and splitting into their ethnic or religious groups. And they would help these communities, once they had a governing council, to then dig a well, to do health education, to build schools, to do development projects that were growing out of this local development council. And what we really noticed is every community that they had worked with over the last 20 years, there weren't insurgents. The young men were not being enticed to go and join any of the militia groups. They were really immunized against violence and insurgency. And now there have been some major studies at where pilot projects in conflict prevention have happened in many different countries. Those communities, even regions, have been immunized, in a sense, from the larger struggles that are going on around them. I want to offer today 5 lessons of what we've learned about conflict prevention and talk a little bit about some of the challenges as the United Nations, the World Bank, the U.S. government, and many other governments around the world now try to figure out how to structure conflict prevention programs into their foreign assistance. The concept of a whole of society or a comprehensive approach to conflict prevention is really the first challenge. So now that these governments and the UN are involved, how do they link with the community groups that are on the ground? In very few countries is there any sort of channel for this kind of communication. So I've worked in Iraq, Afghanistan, Pakistan, and mostly what's happening at conflict prevention at the community level is unknown to the government level, which is why I spend most of my time now educating here in Washington about really the possibility of better partnerships between civil society, government, and military, and thinking about how to solve these problems. In Kenya, though, there was a really good example in 2008, and again this year, in preventing the spread of election violence. Really, Kenya is one of the only countries where there has been whole of society conflict prevention, because actually Fulbright program, which is sponsored by the US, started sending us graduate students, Kenyan graduate students, to the university, Eastern Mennonite University, where we have a master's degree in peace building and conflict prevention. They started 20 years ago sending us their students. There are about 30 Kenyans with master's degrees in conflict prevention. And they have set up NGOs, non-governmental organizations across the country. They've started university programs. There's a whole cadre of trained people in Kenya that were then called upon to stop the election-related violence in 2008 and again this year to preventing it. And they were able then to work with government, with the United Nations, with regional organizations to really get out into the field with peace teams that were mediating conflicts right in the middle of riots and finding ways for there to be a calming and a time where people would go home and things were worked out over the phone in terms of how to handle criminal violence. So Kenya is an example. Ghana is also an example. They have a national infrastructure for conflict prevention in Ghana. The key thing here is building relationships for this whole of society prevention from the beginning. So creating the channels of communication, the places where government and civil society can meet together so that they can talk about what are the driving causes of conflict. And my second point about the 5 lessons is really that there needs to be much more conflict assessment. Because what's happening right now is really, if you listen to the media on Syria, there's a real rush to judgment in terms of what is driving the violence. Conflict assessment is a thorough, systematic process of looking at all the drivers, all the stakeholders that are holding in place the conflict and actually fueling it. So it's much more than just Assad. There's a whole international network here fueling and supporting Assad. So if we think about conflict assessment in Syria, we would look at the whole picture, all the stakeholders, all the interests involved, and thinking about how do we change that system. And civil society needs to be involved in that process because often civil society and government have really different ideas about what is driving conflict. And this was very clear in Afghanistan, where I spent a number of visits over the last 4 or 5 years working in Afghanistan on the ground with peace building, conflict prevention, Afghan NGOs, Afghan initiatives that were working on the ground, and they saw the drivers of conflict very differently than the U.S. government and the U.S. AID, the International Agency for International Development, in terms of how they were putting their money into conflict prevention. The U.S. government wasn't spending a lot on conflict prevention, but mostly it was funding jobs programs because it perceived that the driver of the insurgency was unemployment. So it was trying to get those young men off the streets. But all the Afghan researchers at Kabul University that I was working with, when they went out to the insurgent groups and they were asking what are the critical factors leading you to join the insurgency, unemployment was almost non-existent among their factors about why they were joining the insurgency. Interestingly enough, religious motivations were also very low. Most of them were aggrieved by local political leaders that they thought were corrupt. And they saw the U.S. supporting these corrupt political leaders, putting them actually in place, the provincial governors who used to be warlords, and now were governing with violence and corruption. And so the primary motivation for the insurgency was actually to fight government corruption, which is actually an interest the U.S. had as well. And if we had linked more with civil society to think about corruption as the major driver of the insurgency, rather than unemployment or some of the other issues that the U.S. was looking at, religious extremism, we might have had a completely different approach to the whole conflict in Afghanistan. And so often civil society and government are thinking about conflict in different ways, and they're designing different kinds of conflict prevention programming. And oftentimes those are not in line with each other. They're not coordinated. There's no channels of communication. And civil society tends to take a more structural approach, whereas governments tend to take a more operational approach. And so in Afghanistan, operational meaning forces on the ground trying to kill insurgents, while civil society is saying corruption is the major driver here. We need to figure out how to make this government actually legitimate and accountable to the people. This example of the difference, the lesson learned on operational versus structural forms of prevention also is seen in Kenya. The U.S. government, again, funded a lot of unemployment programs there for the young men who were out in the streets rioting, and certainly they were young, unemployed men, but most of the grievances that civil society hears in Kenya are about land distribution and post-colonial ethnic divisions that happened when the British left, and they left one ethnic group in charge, and the land and the government positions have never really been redistributed, so there's a real hold on Kenya on sort of structural violence, how some ethnic groups discriminate against others and cause disability and death based on those structures. And really, if we want to think about conflict prevention, we have to think about changing the structures and changing how land distribution happens in Kenya, or we'll have continuing violence in future elections. The fourth point, and there's again 5, is that a number of countries are forming special conflict prevention expert teams. The UK is, and Norway and a number of other countries really seeing conflict prevention as an academic specialty, which needs a certain kind of diplomacy. It's not the kind of coercive diplomacy where you're using force to say, well, if you don't do as we say, we'll bomb you, or this sort of coercion of diplomats, but really diplomats who are trained in conflict analysis and resolution, how to look at the structural factors and how to work at incentives and redesign how a country is organized and oriented. So the recommendation here is that we form more negotiation, mediation teams at the highest levels to work with civil society on conflict prevention. And then the final part is about integrated program design and conflict prevention funding pools. The United Kingdom currently has a conflict prevention funding pool, which they offer to the military, the development and diplomacy wings of the UK government to work together to better coordinate their conflict prevention. Here in the US, we have funds called the 1207 funds, which Congress appropriates, again, to influence and to support that sort of coordination. But more of it's needed. There's not enough incentives yet for our State Department, our development agency, USAID, and the Defense Department to work together and to work with civil society to really prevent conflict. All too often, these groups are competing for funds, and they're designing their programs in isolation from each other, and they just don't work when they get on the ground because they're not on the same page, again, about what is driving conflict. So those are my 5 points. Thank you very much.
Dr. Beck is the Vice President for Policy and Strategic Initiatives for the Electric Infrastructure Security Council. Dr. Beck is a technical and policy expert in several homeland security and national defense-related areas, including critical infrastructure protection, cybersecurity, science and technology development, WMD prevention and protection, and emerging threat identification and mitigation. Dr. Beck served as the subcommittee staff director for cybersecurity, infrastructure protection, and science and technology, and was the senior advisor for science and technology for the House Committee on Homeland Security, where he worked from 2005 to 2011. Dr. Beck holds a PhD in physics from Tufts University and a BS in physics from Montana State University. Welcome, Dr. Beck.
Thank you very much. I'd like to thank Dr. Wollman, thank yourself, thank you, Representative Scott, and thanks to the Prevention Project for this forum. Thank you all for being here. I don't have many prepared remarks, but after all the discussion today, I would probably diverge from them pretty quickly anyway. But I want to, the reason I want to do that is because there are a lot of unifying themes here. I'm going to touch a bit on the focus of EIS Council's work, which is electric grid protection with a specific focus on electromagnetic threats. And I'll get into that very briefly. There's a little bit of physics and electrical engineering, but it's nothing anyone in the room can't handle. But I think what's important is the challenges that we face actually are echoed in a lot of the points that the previous speakers made. So I think that when we talk about the ideas of prevention and in the critical infrastructure world, a very related concept is resilience. So I'm going to kind of focus on particular on one or two types of natural disasters, which we can't prevent per se, but we can do things that are like prevention. We can make investments up front with built-in resilience so that when such an accident happens, that we can recover quickly. The other thing I wanted to talk about as a unifying theme is evidence-based approaches and the closely related challenges that I think a lot of the other speakers also pointed out was sharing of information, getting the right data. There seems to be, in certain cases, a lot of studies, and how do we translate that into policy? How do people have that be accessible? And in the particular case of critical infrastructure, there's an additional problem, which is that the data isn't as open. It's not usually academic data, but you have proprietary business information hurdles as well. And so what are the challenges in sharing information sort of among competitors for a common good that is the electric grid. So just to lay a background on electric grid protection from electromagnetic threats, I want to talk what EIS Council does is try to educate industry and government policymakers on this phenomenon called geomagnetic disturbance. And it can come in two flavors, if you will. One is a natural occurrence, which is caused by charged particles from the sun sweeping past Earth, disrupting the Earth's magnetic field. There is a malicious analog, which is a high-altitude burst of a nuclear weapon, which causes charged particles to move through the Earth's magnetic field. So the phenomena is very much the same, and the impacts on the grid are very much the same. There's a second component that to the nuclear weapon part, but I don't want to get too bogged down in that. I'll just say briefly that it has an ability to affect microelectronics, and so it can knock out cell phones and radios and things like that. But I want to focus more on the electric grid as a founding critical infrastructure, because it's pretty much, I think, the backbone of modern societies, and all the other critical infrastructure sectors, which include communications, transportation, finance, food, water, all of those very important infrastructures that we rely on themselves rely on electricity. Now, electricity relies on them too, but it's sort of the first among equals as far as the critical infrastructure. And so it's something that as a society we rely on, and it's so ubiquitous that we take it for granted. In the case of a geomagnetic disturbance, it's not really anyone's fault. It's just that certain types of events like this are often characterized as high-impact, low-frequency events, or HILF events. And that means they don't happen very often, but when they do, they have an enormous impact and high consequences. But it's not something that we as societies or the engineers that design the grid deal with day to day. And so when you do the engineering and the physics for designing the grid, it was out of sight, out of mind, and the grid was built in such a way that it is vulnerable to these types of effects. And the effect is basically that the electric grid systems throughout the world are alternating current systems. And that means that electricity, the electrons wiggle around in the wires at 60 hertz, 60 times per second, and it's synchronized anywhere within a continuous grid. When these geomagnetic disturbances happen, they push direct current into the system. And it's just it's not that the current itself is really strong, but the system is designed to go back and forth at a nice 60 hertz per second, and you put in this other current, and it causes it to operate outside of its normal parameters, and you can have blackouts, and in extreme cases, you can have damage to the large extra high voltage transformers that are kind of the backbone of the system. And if those are damaged, they have very long lead times. It costs several months to order their tens of billions of dollars and several hundred tons. So they're difficult, they're expensive, they're difficult to move, they take a while to get. And so if there was a large scale damage of those, we would have really extremely negative societal consequences. So that's something I would say, I guess, we would want to prevent if we can, and there does seem to be ways to do that. We're learning more about that. The next problem that's equally likely is that you would just have a blackout because of the system getting out of whack. So maybe not widespread equipment damage, but a wide-scale blackout. And I found it very interesting that a lot of the other panelists, Dr. Donarski talked about how the costs for making some investments up front versus the later costs of dealing with the problem. One of the government studies that was done, or 2 or 3 of them actually that came to pretty much the same conclusion. One was that I'm thinking of is the National Academy of Sciences and NASA did a study on the impacts of extreme space weather and found in a very large event, the biggest one we know of happened in 1859. Again, before we really had any electric infrastructure. There were telegraphs and they burst into flames and all kinds of exciting stuff happened, but our societal reliance on that technology was not anything close to what we rely on electricity now. So, this is a 100, 200-year class event. The estimate was $1 to $2 trillion in economic damage and full grid recovery to take 4 to 10 years. So you look at $1 to $2 trillion, probably lots of lost life. I mean, the Congressional EMP Commission estimates, high 75, 80, 90% of the population might not be sustainable because, and their estimate was arrived at by saying, well, before we had an electric grid, the population was about 1/10 of what it is now. And so that's kind of our natural sustainment capacity of the United States. And we leverage our technology to be able for 10 times as many people to live on the same amount of land. It's a ballpark estimate, but it's pretty scary. Now on the what happens if we pay for a little prevention, on the other side of that is if we can protect the transformers, and most estimates there are $1 billion. So $1 billion versus $1 trillion in damages, no lost life versus a lot of lost life. And that $1 billion, because the grid is the assets are there a long time, and they're robust, and you can spread the payments out over several years. So we're talking roughly every ratepayer in the United States paying an additional 20 cents a year to cover the cost. So it's pretty impressive at how much resilience and prevention you can get for some upfront costs, and I'm hearing that from a lot of the other speakers as well. And so I think that theme of looking at ways that we can make smart investments now, and in the cases that I've heard, I feel bad for my fellow panelists because the points that they raise seem to me to be much less esoteric when you're talking about dropout rates and disease prevention. I mean, these are things that we should sort of know about. I mean, I'm kind of over here waving a flag saying there's this really weird thing that happens every 200 years, so we should all be ready for it. But but it's one of those events that, should it happen, the consequences are dire. And so I did mention that one of the difficulties is exchanging information and so on, and it is difficult. There are, thankfully, some progress is being made. The North American Electric Liability Council, or Corporation, NERC, has convened a GMD, Geomagnetic Disturbance Task Force, and the Federal Energy Regulatory Commission in May just issued an order that will start to address GMD. There are activities throughout the world, but much more needs to be done. Dr. Fishbein had a great line, which was, we need to know more, but we know enough to do something. And I think that that's the same case with this. We could always know better. We could do tests on transformers and really understand exactly how the harmonics arise and things like that. But we know enough to know what needs to be prevented, and taking some prudent steps can really save us in the long run. In the case of a geomagnetic disturbance, like a hurricane, like a tornado, it's really just a question of when, not if. I mean, I can't tell you exactly when it will be, or exactly where it will be, or exactly how big it will be, but we do know it will happen. And so we hope that through our efforts of education and working with the industry and with governments that we move forward on that.
We currently know enough about prevention to act now, but we need to know more. More research can help continue to improve the way we effectively address problems and reduce taxpayer burden in our nation. The next congressional briefing will be held on January 14th, 2014, and will focus on how to successfully disseminate, implement, and manage accountability for evidence-based practices. On our website, you can find more information about the congressional briefing and read our article about prevention and its benefits for healthcare, education, criminal justice, the environment, national defense, and infrastructure, and national disaster preparedness. To help us spread the word about the Prevention Project, we ask that you share this video via email, Facebook, or Twitter with everyone who might appreciate sensible strategies for improving taxpayer burdens and societal outcomes. With the help of researchers, academics, practitioners, evaluators, government officials, and others, we can shift the culture of our government to focus on prevention as a win-win strategy for our future.